was actually an exciting topic for me to speak about gastric cancer in Brazil because in the United States we don't have a lot of gastric cancer, yet I spent quite a bit of time in Japan and saw plenty of cases to a point that when I came back to the US I checked myself for Helicobacter pylori just to make sure that I have not contracted any, but I noticed that Brazil actually has a fairly high prevalence of gastric cancer, and it's one of the more common cancers around the world and the third most common cause of cancer death. So far though, we don't have any other strategies to decrease mortality other than early detection and treatment. And that's why I'm going to focus my talk on that particular aspect. I'm not going to talk about fancy stuff, but some practical things that you can introduce immediately in your practice to help your patients. I'm going to talk about screening, diagnosis, and a little bit about surveillance. The first question is who to screen. And we know now there are well-established risk factors for gastric cancer. Helicobacter pylori, by far and away, is the major risk factor for gastric carcinoma. Male sex, increased age, Asian ethnicity, smoking, family history, and finally, diet high in sodium. If you look at screening programs, though, even in countries with a very high incidence of gastric cancer, it's not cost-effective to screen everybody. So if you have a low risk of cancer, you will not screen. And only people at a higher level of risk, such as those male, age greater than 50, Helicobacter pylori positive, are worth consider for screening to be cost-effective. And in general, there is 4 types of screening methods: barium, serum pepsinogen, Helicobacter pylori serology, and endoscopy. Since this is an endoscopy course, I'm going to focus on the endoscopy part because, after all, that is the most effective way to screen. The problem with endoscopy, though, is that actually we miss cancers. This cancer that you see here, it's very difficult to miss. Everybody will see that. But frequently we are dealing with this situation where the cancer is not so obvious. And actually you have to use a staining, in this case with indigo carmine, for the lesion to become more obvious. Wow. I'm sorry, it projects really poorly on the big screen to appreciate the subtle differences. You have to take my word for it. There is an early cancer there on the lesser curve. The fact that we miss cancers at endoscopy has been recognized for quite some time. This is a recent study from this year in clinical gastroenterology and hepatology, where they went through a national database in England, and the bottom line is that about 9% of the patients that were diagnosed with cancer had upper endoscopy 3 to 36 months prior to the cancer diagnosis, meaning that most likely those cancers were missed. And if you look at the findings of endoscopy done prior to the cancer diagnosis, gastric ulcer was the most common finding. So when you see a gastric ulcer, be aware and pay attention for that particular patient. So we know that we miss cancers at endoscopy. The question is how we maximize the yield of our examination. And there is some really simple things that you can do. This is an example where a little bit of bubbles on the mucosal side obscure a fairly obvious ulcer once you clear the bubbles. Here are the bubbles, and here is the ulcer after cleaning the mucus. And then you have a lesion. Do you see any lesion? And nobody can see it with this projection, I'm sorry. But there is a lesion right here, which becomes more obvious again with indigo carmine stain right there. And actually, this is cancer with submucosal invasion. So you don't have to see a big bulky mass in all cancer cases. And that is why those cancers are easy to miss. This is another example of early gastric cancer, and I'm going to highlight the two lesions for you. One is right here, and the other one is here. It has a raised edges and depressed central area. The take-home message is to look for subtle changes in morphology and color. In Europe, they actually have guidelines on how many images to obtain at each upper endoscopy. And the recommendation is to obtain 8 images, 2 in the esophagus, 4 in the stomach, and 2 in the duodenum. In Japan, the guidelines actually call for 22 pictures only in the stomach. Just in the stomach, you have to take 22 pictures. We clearly, in the United States, are lagging badly because we do not have any official recommendation of the number of images to obtain at upper endoscopy. So we have a big black box there. Clearly, our societies, ASG, need to put something forward. The reason pictures are important is because you document, but also in a way makes you look harder and you take your time. And as a result, you probably are giving a better examination. There is a lot of talk about image enhancement, and I already showed you a couple of examples of chromoendoscopy with indigo carmine to help you find lesions. Once you find a lesion, typically in the West we do a biopsy, but in Asia a number of image enhancing technologies such as narrowband imaging, FICE, or Lazero can help you determine whether that is cancer or not. And of course, magnifying endoscopy certainly can be helpful, not available in most Western countries. Another point that I want to make is that once you find the lesion, you have to biopsy it, and you need to biopsy at the right spot. This is an example where a biopsy was obtained at the raised nodular area, right there, and just showed regenerative mucosa, but once the biopsy was obtained into the depressed area, actually showed a well-differentiated adenocarcinoma. So you need to obtain adequate biopsies and biopsy the raised portion of the lesion, but also the depressed portion of the lesion. For intestinal metaplasia and gastric cancer surveillance in the United States, we don't have guidelines by most society, or the guidelines are fairly old and vague. Contrary to that, in Europe, they publish a relatively recent guidelines called the MAPS guidelines, MAPS, which stands for Management of Precancerous Conditions and Lesion in the Stomach. Let me briefly cover those guidelines. Chronic atrophic gastritis and intestinal metaplasia are considered to be precancerous conditions. That is pretty straightforward. Patients with extensive atrophy and extensive intestinal metaplasia should be offered endoscopic surveillance every 3 years. The key is extensive. On the other hand, patients with mild to moderate atrophy or intestinal metaplasia containing only in the antrum do not need a follow-up. So this is one major distinction. Extensive atrophy or intestinal metaplasia, do surveillance. Limited to the antrum atrophy or intestinal metaplasia, no need for surveillance. H. pylori should be performed in atrophic gastritis and may improve histology. Although we still will treat H. pylori in patients with intestinal metaplasia, the histologic findings may not necessarily improve. because frequently Helicobacter pylori is no longer present in patients with extensive intestinal metaplasia. If you find a low or high-grade dysplasia, definitely endoscopic surveillance is recommended, and high-grade dysplasia should be treated endoscopically, typically with endoscopic mucosal resection techniques, endoscopic mucosal resection, EMR, or endoscopic submucosal dissection, ESD. For low-grade dysplasia, if you see a defined lesion such as nodularity, again, that should be treated with endoscopy. If it is in flat mucosa, then that patient needs to be surveyed. I mentioned already that Helicobacter pylori may be absent in intestinal metaplasia focus, particularly of the complete type, but it may be present in areas adjacent to the intestinal metaplasia, which makes the diagnosis of Helicobacter pylori in patients with intestinal metaplasia difficult. And that is further aggravated by the fact that those patients are frequently on proton pump inhibitor, which again decreases the sensitivity of tissue-based sampling, such as histology and urease-based sampling. The bottom line is that other diagnostic tests should be considered in these patients, such as serology, urease, breath test, stool antigen. You should start with some type of a screening program in high-risk patients. And that is usually driven by the government. And we can have some advocacy there, but that is usually a difficult challenge. On the other hand, there are some things we as endoscopists and the endoscopic society such as SOBET can help. It can contribute by promoting high quality of endoscopy, such as having guidelines that reflect the local circumstances here in Brazil. A better training of endoscopists how to perform better upper endoscopy certainly can be embarked on by the national society. If possible, it's a good idea to use sedation during upper endoscopy because it provides for better examination. And although we don't have extensive data on how long we should take to perform one upper endoscopy, the belief is that we should take at minimum 8 minutes, which is frequently, unfortunately, not done. Clear the endoscopic field with mucolytics such as N-acetylcysteine or pronase. Use a systematic examination with photo documentation, and finally, obtain adequate biopsy. Thank you very much.